Well, thanks, Alan, and thanks for having me to the regional rounds, and hello to people in the other sites. So my name is Keith Wilson. There's another name here on the slide, Sarah Beatty, who won't be joining us this morning. Sarah's just had a baby recently, but she was a resident who worked with me last year, and she put a lot of work into this, and so I'd like to acknowledge her for this presentation this morning. We don't have any commercial ties that we would benefit from any of this work. What I would like to do this morning is introduce you to the concept of dignity-conserving care. There is a model for the enhancement of dignity in patients who are medically ill, and I'd like to tell you something about that, introduce you to it, and then tie it into some data that we collected from a research study, a pan-Canadian research study called the National Palliative Care Survey, where we sat down with patients who were receiving palliative care services for cancer and asked them some very basic questions about what's the best thing about the care that you've received over the last few weeks, and what's the worst thing about the care that you've received over the past few weeks. So largely the research part of the presentation this morning is going to be a discussion of qualitative research, narrative responses to these simple questions where people tell us what's the best thing about their care and the worst things about their care. Now, I'm sure everybody knows what the hospital vision statement is, which is to provide each patient with world-class care, exceptional service, and compassion that we would want for our loved ones. So you see that on the hospital vision statement. And the Ottawa Hospital prides itself on being an evidence-based institution. So I guess that means if we went into Medline and the other biomedical research search engines and looked up the word compassion, we would just find an awful lot of empirical research related to compassion. And in fact, when you do that, you don't find very much empirical research related to compassion. It's a value, but it's not necessarily something that is filtered into people thinking about it from a scientific perspective. It's something that we express in our interactions with patients, but it hasn't really filtered down as a research topic. So what is compassion? According to the dictionary, it is the sympathetic consciousness of others' distress together with a desire to alleviate it. Now, I'm going to introduce you to this man, Harvey Chochinov. Harvey is a psychiatrist in Winnipeg. He's a distinguished professor of psychiatry at the University of Manitoba and has just actually been awarded the Order of Canada for some of the work that I'm going to talk about this morning. Harvey has become very interested in the issue of dignity in people who are receiving palliative care services, and for reasons that will become evident in a few minutes. Now, my connection with Harvey goes back about 25 years. There was a time when I was a psychology intern and he was a psychiatry resident at the University of Manitoba. And we became good friends and started kicking around ideas about research projects in palliative care, because that was a real interest of his and research was a real interest of mine. And the first research project that we did together was around the issue of patient attitudes towards euthanasia and physician-assisted suicide. So we interviewed a couple of hundred patients receiving palliative care services for cancer, and tried to identify people who we thought had a very significant desire for their deaths to come soon. This continues to be a very timely topic because just on Wednesday, the Supreme Court of Canada heard an appeal to overturn the euthanasia law. So this continues to be an ongoing topic of concern. So that was the work that we originally had done together, which led eventually to this interest that Harvey and I developed around the topic of dignity. So just to refreshing your memories about what's happening lately around the euthanasia debate. In Washington State, and in the U.S. state of Oregon, they have legalized assisted suicide in the American states, and they've legalized euthanasia-assisted suicide in the Netherlands. This is and we asked ourselves, you know, why would patients want to have an assisted suicide if we legalize these things? So this study from Oregon was a large survey of physicians, or Washington State rather, was a large survey of patients, or physicians, who had been asked by patients for assistance in ending their lives. And if they had been asked, then the physicians were also asked, well, why did patients want you to help them kill themselves? And it's a very interesting list of reasons that physicians give. Patients want to feel like they're in control of their end-of-life circumstances. They don't want to be a burden to their family members. They don't want to be dependent for personal care. Some of them are depressed. And some of them do, of course, complain of physical discomfort and pain, but loss of dignity is actually one of the more prominent issues that physicians say that their patients are looking for assisted suicide for. So in the mind of the general public, this is a debate that is largely about physical symptoms and providing compassionate end-of-life care, which may include helping the patient end their lives. But the reality of the situation seems to be that some psychosocial and existential issues, including loss of dignity, seem to be very important in driving patient requests. When we look at the Netherlands, that has had legalized euthanasia and assisted suicide for some time, we know that about 3% of all deaths in the Netherlands take place with these practices. For people who would be seen as the traditional palliative care population, it may be as high as 7%. And in the Netherlands, too, they've done these interviews with physicians and say, when patients come to you asking for euthanasia or assisted suicide, why do they want it? And in the Netherlands, the main reason why they want assisted suicide is loss of dignity as they approach the end of life. Other circumstances are certainly prevalent in there, but you could see in the context of 25 years ago, Harvey and I standing around the hallways at the University of Manitoba, getting very interested in this issue of loss of dignity and its relationship to end-of-life care, because it's not all about pain. The term death with dignity has largely come to be synonymous with the provision of euthanasia and assisted suicide. So this article from the New England Journal of Medicine talks about how Washington State implemented what they called their death with dignity legislation when they legalized assisted suicide. So that got us thinking about how do you study loss of dignity? And it seems to be a very important issue. It's driving patients to consider putting an end to their lives, and yet, like compassion, you take a look at the Medline and try to find out how many empirical studies are out there about loss of dignity. You don't find very much. So Harvey began a program of research examining the loss of dignity in patients receiving palliative care for cancer, and he's developed a model that he calls the Dignity Conserving Care Model. And I'd like to share that with you this morning and tell you what the main points of that are. Basically, the idea is that there are three main dimensions that can diminish a patient's sense of dignity. And one of those dimensions has to do with the illness itself. Another aspect has to do with the patient and the cognitive perspective that they bring to their circumstances. And the third dimension has to do with the way that the patient is treated by other people around them. To flesh out the model a little more fully, things that have to do with the illness itself are how much dependence the patient requires, how much help that they need to do things. You can imagine that concerns about personal care and personal hygiene issues are a factor that contribute to patients' loss of dignity. Now, Harvey and his group came up with this model on the basis of qualitative research with terminally ill patients receiving palliative care services. So they basically sat down at the bedside and interviewed patients in a qualitative way about what is it that serves to maintain their sense of dignity, what is it that serves to diminish their sense of dignity. The dignity-conserving repertoire is the attitudes and behaviors that the patient brings to their circumstances. The way they see their role in the circumstances, the way that they reflect back on their life, the way that they consider themselves to have been satisfied or dissatisfied with their role in life, the sense of generativity and legacy that they're leaving to other people. Their ability to, in some ways, live in the moment. Gary Roden at the University of Toronto talks about patients maintaining a dual awareness as they approach the end of their lives. That is, that they have a realization that they have a terminal illness that is going to take their life, but at the same time people have to live in the moment. They have to do the tasks that are required of them today as well. So there's two realities for some patients. There's the reality of being and living, and then there's the reality that there's a terminal illness that will take their lives eventually. Now, Harvey has actually developed a kind of psychotherapy that he calls dignity psychotherapy that is based on interviewing patients about their past experience, about their greatest values, about lessons that they've learned in life, about messages that they would like to convey to family members. And it's a very interesting form of therapy that produces a written document that the patient has been helped to create, that is a legacy document that is left for the family members after the patient has died. And then we have the social dignity inventory that has to do with the way that the patient interacts with other people in the social world and the way that the social world interacts with the patient. And by that I mean the family for sure, and friends, and the larger social network, but also healthcare providers who are interacting with the patient. They become part of the patient's social dignity inventory. And as we reflect on the topic of compassion, we think that the issue of compassion falls within the social dignity inventory, particularly with respect to healthcare providers' recognition of privacy concerns, support concerns, and care tenor. That is just the quality of the interaction and the quality of the interpersonal care, the interpersonal manner that the healthcare professional uses in their interaction with the patient. Now, as we embarked on a program of research that was going to be related to issues like loss of dignity, we did have a bit of a research conundrum, and that is, how do you measure things like loss of dignity? Or, for example, how do you measure things like feeling like a burden to family members? When we think back to that list of issues of what are driving patients to make requests for euthanasia and assisted suicide, many of them were complex existential psychosocial concerns for which there is really no way to measure. So step number one in this was to develop a way of assessing some of these existential and other concerns. Now, in mental health research, we have a tradition of using structured interviews in order to provide some reliability to assessments that we do of patients. So we thought the structured interview approach to the assessment of existential concerns in palliative care might be something that we could adapt. So basically, a structured interview is a structured set of questions that a clinician would read to the patient and then engage the patient in a dialogue about how severely they might be experiencing each of these things. And so our first attempt at developing a structured interview was, we call it the Structured Interview of Symptoms and Concerns, and we published that a few years ago. So it covers a range of physical problems, it covers a range of existential concerns, it covers mental health issues, it covers some social concerns, and they all follow a similar format of just engaging the patient in a dialogue about how they feel about this particular problem, and then the clinician making a rating of how severe a problem it seems to be, and that can range from no problem at all through to, yes, they feel like they've got a bit of an issue in this area, but it's not something that they consider to be particularly troublesome. And then there are people who score in the moderate to extreme range on our rating scale. And they are people who have told us, I feel that I have a problem in this particular area. So here is the item on the structured interview of symptoms and concerns that we use to talk to patients about their loss of dignity. Do you feel that you're able to maintain your dignity and self-respect? Even though you may need help with some things, is your sense of dignity basically intact? Do your medical problems make you feel ashamed, degraded, or embarrassed? Do you feel devalued as a person? So we started asking patients this, and we've done it quite a lot now. And we really had no idea how common it was going to be for patients to experience a loss of dignity. But here's what we've been finding. This is 4 different studies where we have used that loss of dignity item across different populations, all of whom have been receiving palliative care for cancer. And all the studies are basically pointing to the same thing with respect to how common is a loss of dignity. And that is, most patients say, I'm fine. Most patients say, I don't really experience a loss of dignity at all. It's over half of the patients in all of these studies. And then there's another group, depending on which study that we've done, between 15 and 40% will say, well, yeah, a little bit. It does bother me to some extent, but I wouldn't go so far as to characterize it as something that's really bothering me a lot. I don't put it down as a problem that we need to do something about. But then there is this other group of between 6 and 10% of people who feel that the loss of dignity is a very significant issue for them. We find similar kinds of distributions when we ask about other types of existential concerns among the palliative care population too. That is, most people say they're doing pretty well with respect to existential. People don't generally feel they're in an existential crisis. They generally feel like they're coping pretty well. But there is this pocket of people, 7 to 10%, that feel like they've got a real significant struggle existentially, including in the loss of dignity. The largest study that we've done where we've addressed this set of issues has been the Canadian National Palliative Care Survey, which was a multi-center study that we conducted in the early part of the 2000s. Where we recruited close to 400 patients at 8 sites across the country and did very in-depth interviews with each one of the patients, where the interviews were tape recorded so that we could have some qualitative information as well as quantitative information about some of their health-related quality of life concerns. It was coast to coast in both official languages, and some of the data that I'm going to present to you today have to do with our findings from that study. Now, to give you an idea of the scope of it, and also to give you a sense of who the patients are that participated in the study, in order to do this, we were looking to interview patients who were terminally ill and within their last few months of life, receiving palliative care services for cancer, but were well enough and willing to do an interview that would take about an hour, where they address quite a number of in-depth concerns. Their social issues, their mental health, their attitudes about certain social policy concerns, and issues around existential questions like the loss of dignity. Now, most patients who receive palliative care services, we found, are just too sick by the time they get a palliative care referral, for anybody to come and have any possibility of sitting down and conducting an in-depth research interview with them. So for various reasons, winnowing down through this flow chart, you see that of over 7,000 patients who were admitted to the palliative care services, by far most of those patients were not able to participate in any kind of research like this. And we got completed interviews of 340 some patients that addressed the issues that I'm going to talk about today. There are quite a lot of things that we talked about in this in the interview protocol, and the ones that I'm going to focus on came right at the very end of the interview, where we asked patients about the best and worst aspects of the care that they'd received over the last few weeks. And we've published, this is just a list of publications that have come out of this data set, but we've published on things from suffering and the prevalence of anxiety and depressive disorders, and we published on pain, quite a number. It's been a rich data set. And at the very end of the interview, we just asked the patients these very simple, open-ended questions. From your point of view, what has been the best thing about the care you've received during the past few weeks? And what has been the worst thing about the care that you've received over the past few weeks? And so these were tape-recorded interviews, and the recordings went back to a transcriptionist who typed up all the answers, and then we met as an interdisciplinary team, brought people in from across the country who were involved in it, and we content analyzed the different themes that patients have told us in their narrative responses to these questions. So it gets divided into two broad categories at this part. What are the best aspects of care? And what are the worst aspects of care? And I'll just go through what they are. By far, patients are more likely to be able to identify the best aspects of care than they are the worst. By and large, patients are pretty satisfied with the care that they receive. And it's much easier for them to tell us about positive things that happen than about negative things that happen. So we get a lot more, just in terms of the number of statements that people tell us, we get a lot more statements that are positive than they are negative. And those 504 statements get broken down into 5 larger domains that have to do with the system, the healthcare system, that have to do with positive interpersonal manner, that we think is part of the expression of compassionate care in the social dignity inventory, if we want to use those words. The adequacy of the clinical care, this is how well they think they were treated from a medical, technical healthcare perspective, how involved they were able to be in their care. And then people had, believe it or not, some interesting things to say about the environment of care, the places that they were in. About half the patients were in palliative care units, and the other half were either in home care or they were receiving palliative care consultation services in general hospitals like this one. About 100 of the patients came from Ottawa. When patients talked about system assets, they were grateful to have care available to them that met their complex needs. So a representative quote, "The availability, it's so important, that's my number one. Easy access to these people who are really dedicated to work under some pretty unusual time constraints." Some people talked about the continuity of care, which transitioning from one place to another place or from one team to another team, they felt that communication and consistency was something that they valued. The most common thing that people talked about was actually compassion. The compassionate care of the staff, their kind and loving approach. They do it because they want to, not because they have to. Somehow, people are doing a pretty good job of communicating that to their patients. Maintaining dignity. I think that it's probably that everybody treats me with dignity. They respect my opinion. They take the time to listen to what I have to say. Some people like staff with a smile on their face. Positive staff attitude. Be upbeat while presenting hard facts. Don't erode hope. Balance hard facts with some good news. People talked about having a special therapeutic relationship with some of the clinicians that were caring for them. Doctors can be very cold at times, but my surgeon held my hand. He's so kind. A little kindness helps. No sick person wants sympathy. We want caring and laughter. This person does. People talked about the adequacy of the clinical care, either just in kind of generically good terms of good care, they treat me like a queen, or that the system was quite responsive to what they needed. The willingness of everyone on staff to give me what I needed or wanted as quickly as they could. Feeling that they were treated with some respect when they were helping people with personal care. The general physical care is good. Bathing, cleaning, feeding, personal needs are taken care of. And they felt grateful again to be treated by staff that seemed to be competent in the provision of care. Everybody seems to be qualified in the jobs that they do, from the nurses right down to the girl that washes the floor. Of course, patients talked about the relief of symptoms. They're receiving palliative care, so most of these patients have quite significant physical symptoms. This person said, I haven't suffered any pain for any length of time. Anytime I had pain within half an hour, it was all cleared up, and so I haven't had to suffer any pain or worry about when it was going to come back or anything. So again, the idea of responsive care happening quickly enough when the patient needs it and provided by a competent staff. Patients, many, spoke of valuing being involved in decisions that were being made about their care. When the doctor comes and talks to you and tells you what's going on, keeps you informed when she brings someone else in. Patients valued being told the truth, especially in here the honesty. They don't try to BS you and say, well, this is guaranteed that it will take your pain away. So on the one hand, we have patients who are saying, balance bad news in a way that is respectful of our hopes and fears, but at the same time, don't BS us. Some people like the hospital environment. I get 3 good squares a day, a good bed, and I've got women to look at. So those are the positive aspects of care that the patients in the National Palliative Care Survey told us about. And then we also asked them about what are the worst things about the care that you've received over the last few weeks. Now, in some ways, hearing about the worst care can be more instructive, because you hear about the best care, we can pat ourselves on the back and say, well, we're doing a good job there. You hear about the worst care, and perhaps there is some pause for reflection as to how we might be able to do a better job in some ways. Far fewer statements, though. Patients had a much harder time thinking of bad things. So in general, the good certainly outweigh the bad. And like the best aspects of care, we have 5 domains covering the worst aspects of care, many of which are just the mirror image of what we had seen for the best aspects of care, except now they're bad. So personal illness experience, patient talked about. A negative environment, we saw a little bit about the positive environment before, but some patient says this is a negative environment. Poor clinical care, as opposed to good clinical care. System deficits, as opposed to system assets. And negative interpersonal manner on the part of the staff rather than positive. And so the kind of things that patients told us, well, they told us about their illness. Remember, the first part of the dignity model has to do with the way that a patient's illness can diminish their sense of dignity. And we certainly heard that from the patients in the course of this study when we asked about their care. This wasn't so much focused on the care as it was focused on their overall experience of illness. There's no good thing about this. They've taken out half my guts and they have me in bed where I can get up and do nothing. People talked about the lack of control. When that bar goes up, talking about the bar on their bed, it's time for bed, I feel like a prisoner. Some people find that being dependent on others for the provision of personal care is something that they find demeaning and imposes on them a sense of loss of dignity. Loss of dignity because of my bowel control. It's humiliating to have your bum out in the world. Some people talked about a negative environment. Being in the hospital is not a great place to be. The loss of privacy for some, I find it hard to deal with. And a statement that we weren't surprised to hear about, the food is terrible. Some patients felt that they were receiving poor or even incompetent clinical care. There's always the odd person that doesn't know what they're doing, they're running around, they're panicking. Rarely, but sometimes, these are some categories that are probably worth just talking about. Some patients felt like they had been left alone for long periods of time and being abandoned. Some people felt that they had been treated negligently by a member of the healthcare team. Some people felt that it took an awful long time to bring some of their symptoms under control when perhaps more timely care would have been able to provide them with better relief sooner. Some people found that the system is just kind of rusty and doesn't move very quickly. I had a lot of challenges to get stuff done. I had to fight a lot for the things that I had done throughout. The worst thing is, you have to go, you have to go. They don't know what they're talking about. Go where? This is somebody who's talking about their experience of the hospital wants to discharge them. They're terminally ill. They don't really have any place to go. The worst thing is, you have to go, you have to go. They don't know what they're talking about. Go where? Home? In other words, if they can't cure me in 10 days, 12 days, I might as well take off. They have no place for me. They also told me that there's no opening here any place. For long-term care, yes, the place next door apparently, but there's no opening there for the next 2 years. So somebody who's under a lot of stress because there are placement issues in their care, not an optimal situation for coming to terms with your end of life. Lack of continuity of care. I think there's one thing that I've noticed, and that there's too many hands in the pot. Some people talked about perhaps having a quarterback, a champion, someone who is the guide through the process. And some places have that, and some places don't. I've had more questions, the same asked by more people. Absolutely, it was unreal over and over and over again. And I think I'm certainly guilty of this because I work on an interdisciplinary team. And when I go in and start doing an assessment with the patient, I want to hear from, the story from square one. But they've maybe told 5 or 6 other people the story from square one too. And they're getting a little tired of it. Some patients noted a lack of resources, insufficient resources in people. People shouldn't have to wait to be cleaned, long waits, being late with medication, not having it on time. Some people had to wait a long time for diagnosis or treatment, or that some of the care that they received was rushed. Negative interpersonal manner is certainly part of the social dignity inventory, and this is staff members who are interacting in a negative way with patients. Condescending behavior. I did run into one doctor here the first time I came in with my daughter. He started asking her questions, and I said, why are you asking her questions? I'm the one that's sick. Talk to me. Feeling ignored. I find that as a patient, I don't know what the doctors know, and I told my doctor, is it possible for the patient to speak up? He said yes, but the patient's not always listened to. When they ignore you, you're hurt. You try to tell them what's wrong, and they don't listen. They leave. Inconsiderate care. Indifference. People come into the ward and they're tired and rough when they deal with you. Lack of humanity. Manque de chaleur humaine. Je me sens même plus bas qu'un animal. It's a strong statement. Being indifferent to one's pain and one's suffering. Poor communication with staff members. I was having trouble getting information about my drug doses and stuff like that, but I think it was a matter of not knowing what to ask, and I was very sick. We did hear a couple, not many, but a few comments about patients having had bad news broken to them in a way that we characterize as being cold. and impersonal. Some just don't bother. Like that one doctor, when I want to ask questions, he says, let's not concern ourselves about that. You're full of cancer, your middle's full of it, you're dying, and you have 1 year to live. He didn't close the curtains or nothing. People were watching, my husband, daughter, and I was crying and stuff like that. So those have to do with the narrative comments that patients tell us about the best aspects and worst aspects of palliative care. Now, Harvey has reflected on some of this work, and he's come up with what he calls the ABCD model, a nice little memorable acronym for things to keep in mind as you're interacting with a patient and hoping to keep their sense of dignity in mind. ABCD stands for attitudes, behaviors, compassions, and dialogue. Attitudes, he suggests that we reflect on our own experiences and what we would want if we were in the patient's shoes. Some people may be here from a mental health background. Are there countertransference issues that we may have as we're dealing with people who are very ill? Do we have assumptions about what it must feel like? And there's some ways to engage in continually debriefing ourselves and discussing with colleagues what our attitudes are. Behaviors have to do with the nature of the way that we interact with the patients, remembering to some of those basic principles of dignity, treating them with respect, getting down at eye level with people, using the language that they're likely to understand rather than speaking at a level that maybe require a high knowledge of medical jargon. The expression of compassion, which can be nonverbal behaviors, a sense of connection to the individual. Like, as we say in our vision statement, the kind of care we would want a family member to receive if they were in similar circumstances. And then having a dialogue with the individual. Harvey has some interesting research projects going on where he basically sits down and says to the patient, tell me a few things that I need to know about you as a person in order to provide you with the best possible care. And so they get a little dialogue going with the patient, and they find out some very unique and in many cases quite poignant and revealing stories about what the person is like, not the patient, the person. And then they write this up and they put it in the patient's hospital chart for all the healthcare staff that are interacting with the patient that see, and they can say, oh, this person is a wonderful piano player, and they've got 3 kids, and one of them lives off some. So they get the story in a very brief way of what the patient is like as a person. And it's kind of interesting because it does apparently open up the eyes of the staff who are interacting with the patient. I'm going to return just at the end here to the concept of loss of dignity. All of this work so far has been done with patients who are receiving palliative care for cancer. Over at the rehab center, we don't do palliative care for cancer, but we do have programs for people for whom end-of-life issues are a concern. We have a large program for people with chronic obstructive pulmonary disease, which in some respects is bridging diagnosis between the world of rehabilitation, because we have a functional restoration program for people with COPD where they get a lot of physio, they get some work on mental health issues, and we try to get them to be as functionally vigorous as they're able to be. But at the same time, this is a disease that is likely to kill many of these people and eventually. So there is a palliative care dimension and sensibility that can be brought to it. So we have been asking patients in our COPD program about their loss of dignity using that same structured interview item as I showed you earlier. Do you feel that you're able to maintain your dignity and self-respect? And just like we find in palliative cancer care, we find that most patients, now in this graph we have 195 patients who have been interviewed with this. Most patients tell us, my sense of dignity is fine, thanks. So that was over 90 people out of 195 says, I have no loss of dignity. Then there's this other group in this sample of about 195, there's about 70 people who say, well, you know, I do sometimes experience some loss of dignity, but I don't consider it a big deal or a big problem. And then there is a group at the moderate to extreme level on this graph. That's 25 people in this slide who say that loss of dignity is a significant concern for me. It's a problem. And so These 25 people now come into a rehab program over at the Rehabilitation Center, and we're kind of interested to see whether or not their sense of dignity improves as a result of participating in rehabilitation. And what we find in that group of 25 people who start off with a loss of dignity that is rated as strong loss of dignity, we find that there's a robust improvement as a result of having had participation in the rehab program. So at some level, with respect to enhancing patients' loss of dignity, we're doing something right over at the rehab center, and it probably has to do with living the vision of providing compassionate care. And in this week, as the Supreme Court of Canada debates and hears appeals about the possible legalization of euthanasia and physician-assisted suicide, that we have seen is grounded to a not inconsiderable extent in the issue of loss of dignity. It's curious to me that loss of dignity is something that can be improved with appropriate care. It seems that loss of dignity is a sense that people have of themselves in their circumstances and their perceptions of the way that others are interacting with them, but it is something that can be helped with appropriate care. And it reminds us, and I just clipped this out of the Ottawa Citizen yesterday, this slide, that was a commentary in response to the Supreme Court hearings, that there can be dignity in all states of life, including people who are nearing the ends of their lives. So it's a very interesting time in the euthanasia-assisted suicide debate in Canada, but regardless of what happens with the law, it's important to remember that the preservation, maintenance, and enhancement of a patient's sense of dignity is achievable. It's in keeping with the mission of the hospital, and it's something that we should all keep in the back of our minds, if not in the front of our minds. And for those of you that are interested in learning more about dignity, Harvey's group in Winnipeg has a Dignity in Care website where there's a lot of resources that addresses this kind of issue. dignityandcare.ca. Thank you.